welcome back. Hopefully you all had a restful break and have refilled coffee, water, beverages. Up next for our critical care symposium, I'm so happy to introduce a really good friend, Dr. Evie Marcolini. As you can see, Evie is an associate professor of emergency medicine and neurology and practices both emergency medicine and in the neurosciences ICU at Dartmouth Hitchcock Medical Center. Evie is widely known across the US and the world as one of our neurocritical care experts. You hear her very frequently on emergency medicine reviews and perspectives. She is also, from an administrative standpoint, the vice chair of faculty affairs at the Geisel School of Medicine at Dartmouth. She has been the past chair of the critical care section of the American College of Emergency Physicians and has really lectured nationally, internationally, and has won a tremendous amount of teaching awards. But Evie, I think the best tagline for you is that last in the lower left, that you're simply a big fan of University of Maryland emergency medicine. And as many of you know, Evie, we did have the pleasure of having Evie on faculty for a little bit here before she headed north. So to bring us up to date on really one of the tough cases in emergency medicine, critical care, and resuscitation is really what to do, some very key pearls in managing the patient who is herniating from a neurologic catastrophe. So Dr. Marcolini, take it away.
Thank you, Mike, for that introduction. It's such an honor to be part of this 10th anniversary conference alongside all these great speakers. I just wish that I could be there in person. And truly, it's always a treat for me when I can see Dr. Brown, Dr. Winters, and Dr. Bound. But it's great to see that we have participants from so many places, from New Zealand to Pakistan to Philadelphia. I'm thrilled to bring you two cases that I love because they emphasize that we make critical decisions in emergency medicine with limited information every single day. And that's what makes our job so exciting. I have no disclosures. So let's go to the first case. This is a case of a young man. He's in his early 20s. He works as a tree surgeon. He was on the ground when a limb fell from a tree, not a limb that's this big, but it did fall and hit him right in the head. He was down, he was out, and his workmates couldn't get him to wake up. So EMS was called, and they arrived, and they found him to have some head trauma evidence, but nothing below the neck. And his GCS was 6. He was not responding. So they started some oxygen. His vital signs were okay. His blood pressure was systolic of 120. His heart rate was in the 90s. And he was oxygenating. They could not get him intubated. So they bring him to you. And when he gets to your emergency department, you know something bad is brewing because this is a young, healthy guy. He's unresponsive, and he was hit by a tree. So you're trying to figure out, what do I do next? And what you're doing is you're using your intuitive thinking. Now, intuitive and analytic thinking are two different things. If we used analytic thinking, we would get a CT, and we would see that he may have a subdural, an epidural, a parenchymal bleed with a skull fracture, maybe intraventricular blood or subarachnoid blood, maybe even diffuse axonal injury. All of these constitute TBI. But you don't have that yet. You are standing there in the bay with the patient who's unresponsive, and you have to use your intuitive thinking. So you're thinking about intracranial pressure. You know that there's only 3 things in the skull. That's brain, blood, and CSF. And now, if this young man has a bleed, he's going to have a bleed plus some edema, and that's going to create increasing intracranial pressure. The problem with that is, as that pressure increases, it's going to start clamping down on the arteries. And the arteries are what we need for cerebral perfusion. So you're thinking about that. You're thinking, well, if the ICP goes up, the mean arterial pressure has to go up to match or best it so that we can maintain cerebral perfusion pressure. And this is what goes on in your brain as you're trying to help this young man. Now, the brain's already going to start working to increase that mean arterial pressure. We're there to help it. Well, what about CPP? We know that we want to maintain about 60 to 70, because if we have CPP goals that are higher than 70, we're likely going to be given a lot of fluid, we'll create pulmonary problems, etc. So the Brain Trauma Foundation tells us 60 to 70 is the goal. But wait a minute, we're in the emergency department. We don't know what the ICP is. We don't even have a CAT scan yet. So what do? The one thing we know is helpful is to avoid hypotension. This is really important. We know from data back in the 90s that one episode of systolic blood pressure less than 90 increases the mortality of our TBI patients by greater than 100%. So that's simple. Avoid hypotension. It's in the guidelines for the management of severe TBI. These guidelines were updated last in 2016, and they actually give us systolic numbers to go by. And I want to emphasize here that traumatic brain injury is only one of the 4 common neurologic disasters that we see in the emergency department, and they all have their own special blood pressure goals. If the patient has a spontaneous bleed, hemorrhagic stroke, or a subarachnoid hemorrhage, we want to keep pressures down. But if they have ischemic stroke or traumatic brain injury, we're focusing on keeping blood pressures up, and they're all different. Fortunately, we have this guideline from the Brain Trauma Foundation that says if your patient is 50 to 69 years old, systolic blood pressure should be greater than 100. If they're younger than 50 or greater than 69, it should be greater than 110 systolic. Now, that seems kind of odd, doesn't it, as a guideline? Well, the reason is because there's not a whole lot of prospective randomized data on what to do with blood pressure in TBI patients. They did find one study that was done that had a significant number of patients, and it happened to use these parameters. So that's why we have these parameters. But suffice it to say, we know that higher blood pressure is better. This is a really nice study that Dan Spate did back in 2017, where anybody pre-hospital who had severe TBI was enrolled in the study right in the field. And what they did was they measured their blood pressure through pre-hospital into the emergency department and into the hospital. And they showed us that every 5-point increment increase in the blood pressure for those patients improved outcome all the way up to 135 systolic. So that's a study that's older, and we are still seeing more and more data that shows that blood pressure is good in traumatic brain injury. And I hope that makes sense because we're trying to keep those cerebral arteries open. And we will see more data coming out on blood pressure. But in the meantime, what are we going to do with this patient? Well, of course, we're going to intubate him. We used etomidate and rocuronium to intubate him. And while he was being intubated, his heart rate dropped to 30 intermittently. Now, that was worrisome, as I think you know, because we're thinking about pushing. We're thinking about that reflex that the brain is doing to take care of itself, to keep that cerebral perfusion going. So we quickly finished the intubation and got him to the CT, and this is what we found. This is a young brain, and he's got 10 millimeters of subdural hemorrhage on the left. And the edema associated with that is helping to push that midline 1.3 centimeters over, and we have obliterated the left lateral ventricle. This is bad news. So this patient actually went up to the ICU. He went to the surgical ICU. And while the residents were taking care of him, he started getting agitated, and his blood pressure started climbing higher and higher. I was next door in the neuro ICU, so they called me and said, "Can you come over and take a look at this? His blood pressure is going high, so we've hung some nicardipine." Now, I hope you're thinking what I'm thinking. He doesn't need nicardipine. He needs that blood pressure. His brain is trying to increase the mean arterial pressure because either he's got a rebleed or an expanding bleed or more edema, and his ICP is going up. So we stopped the nicardipine and we started thinking about what are we going to do for this ICP problem? And I think about this in tiers. The first tier is the simple stuff. These are the things that we can do even in the emergency department. Keep that head of bed up to let the blood flow through the jugular venous system. Treat with analgesia and sedation. When you treat pain, you're going to decrease that cerebral metabolism. Use osmotic therapy. And of course, if it's an opportunity, manage the fever. So let's talk about that. I like fentanyl. I like putting up a fentanyl infusion. It's titratable. I can use it. I can turn it off quickly to get an exam when I need it. So we did start a fentanyl infusion for this patient. As far as sedation goes, we want them to be sedated. And this guy was probably waking up from his rocuronium and not adequately sedated. One of the key things we have to be very careful of. So you could use midazolam or propofol, but those are going to drop the pressure. And I'm a little worried in this young, healthy guy about dropping his pressure. You can use dexmedetomidine. You can use etomidate or even ketamine. So let's talk about ketamine a little bit. We used to think don't use ketamine in TBI because you're going to increase the blood pressure. But when you think about it, increasing the blood pressure is what he needs to maintain his cerebral perfusion pressure. We happened to have etomidate close by, so we used etomidate and we sedated him and started that fentanyl infusion. The next thing we did was hyperosmolar therapy. You can use either sugar or salt, mannitol, hypertonic saline. We have mannitol was handy. We had a nice peripheral line, so we gave him 1 gram per kilo. Don't go small on here. Give 1 gram to 1.5 grams per kilo because you're trying to get that osmotic pull of getting the fluid out of the parenchyma into the vasculature and out of the brain. Also, hypertonic saline is a great option here because with mannitol, that patient's going to diurese and you worry about the blood volume and the blood pressure dropping with that. We had fluid hanging while we did that. We also gave him a 30 cc bolus of 23% hypertonic saline. I'm not going to lie, you're supposed to put this through a central line, but we had a really big IV in the AC on the other arm, so we very carefully pushed 23%. We were really concerned about this patient. And after you do that, you're moving on to tier 2 if you need to. Tier 2 is where we dig in a little bit. He needs a ventriculostomy for 2 reasons. First of all, we can measure the ICP and see actually what we're doing and what's going on here. But maybe more importantly right now, we can drain CSF to buy more real estate within the skull. So we called neurosurgery and said, please come by and give us a ventriculostomy. The other things you can do using vasoactives, you can start phenylephrine, which is the preferred agent in the neuro patient. That will increase your MEP to combat that ICP. If you happen to have an older patient with cardiomyopathy or some kind of a cardiac limitation, you can consider inodilators like milrinone, but we reach for the phenylephrine, maybe even the levo. And paralytics help here. We actually gave this patient 1 dose of vecuronium, and that paralyzes him, but it also decreases pressure. And hyperventilation, let's talk about that. We always like to think about hyperventilation, but I want to give you some caveats. When we hyperventilate, we're blowing off CO2 and causing cerebral vasoconstriction. That's great. It's buying us time, but it causes cerebrospinal fluid alkalosis, and the brain reads that. And then the brain buffers this and brings the pH back to normal. What happens after that? Vasodilation. So you just reversed all that cerebrospinal vasoconstriction that you had, and now it's not effective. In the first 24 hours of a traumatic brain injury, the brain is exquisitely sensitive. So hyperventilating is really effective to bring down ICP, to give you some more space, but it can also cause stroke because of that increased sensitivity of that injured brain. So we're very careful with hyperventilation. And I think of it, I'm using it if I'm going to have a pop-off valve of some kind. Am I going to have a ventriculostomy soon where I can drain CSF to help me? Or am I going to the OR for craniectomy? I'm very careful about hyperventilation. The third tier for refractory ICP is what we call the kitchen sink. Therapeutic hypothermia has been trialed, and we showed that it does decrease ICP, but it hasn't borne out an improved outcome for TBI patients. So it's not really used. If we're in the ICU, we can think about a phenobarbital burst suppression. This is for the patient who's already hooked up to an EEG and we can see what's going on there. But we're asking for trouble because it affects the heart, the GI system, the immune system. Phenobarbital is really one of the last choices. One of the early choices that you can do with a young patient like this is a craniectomy. Take part of that skull off and allow the edema to swell outside instead of down onto the brainstem. And if you think abdominal XLAP was a mistake on this slide, I would encourage you to check out this podcast. This is Scott Weingart. This is an old podcast, but he's interviewing Dr. Tom Scalea about a patient who had refractory ICP, refractory to everything. And those of you who work and rotate at shock trauma know that everything really does mean everything. Listen to this podcast and you'll see how an abdominal XLAP helped that patient. So we did take this patient down to get a scan. We wanted to see if there was an expanding bleed or anything else going on. And we took him right from the scan to the OR, and he had a craniectomy. And you can see here how great that is. Took part of that skull off, a nice big piece, and he's got room to expand outside the borders. We can see the lateral ventricle again. The midline is where it should be. And this patient did actually really well. He stayed in the hospital for a while. He got out to rehab, and he did actually quite well. So things to remember. Think about increasing ICP. You know what's going on even before you get the CT because you know the story, you know the exam, and you have intuitive thinking. In the emergency department, keep the head of bed up, give analgesia, think about sedation, and think about osmotic therapy. That's great early on. But also think about the second tier. Get a ventriculostomy on board. Think about vasoactives if you need them. Paralytics are your friend in the ICP world. And really be careful with hyperventilation. But if you're heading down that road, use it. Phenobarbital burst suppression is something that we use in the ICU. It's an option. And hopefully you're not holding on to this patient that long, but you want to have EEG in place if you're going to use that. And craniectomy is very useful for especially young patients early on in their TBI course. So the pearls from this case are: anticipate that ICP and think about your cerebral perfusion pressure and how you want to keep the mean arterial pressure on the high side. And then know what's in your ICP toolkit. Let's move on to another case. This is an 80-year-old guy who's riding bikes with his wife. He was wearing a helmet and he went down. She didn't see this happen because she was out ahead of him. But at one point, she just turned around because it got kind of quiet and she notices he's down. So she goes back to find him and he's awake, but he doesn't remember a thing. And he's perseverating. He keeps asking about his pants and his dentures for some reason. So EMS picks him up. She calls and they come and pick him up and they bring him to the emergency department. And what you notice is that he's got abrasions in his scalp, his shoulder, his flank, all down the left side. And he's somewhat tender in his chest wall. His pupils are equal and reactive. He's moving all his extremities, but he can't remember a thing. And by the way, he's perseverating. You can see his blood pressure here, and you do an EFAST, and it's negative. So what are we worried about? I know you're thinking, I'm worried about that blood pressure. But I want you to go back and think earlier than that. How did he fall and why did he fall? We really don't know, but we have to think about those possibilities because if he fell and then had an intracranial hemorrhage, that's very different from having a spontaneous intracerebral hemorrhage causing him to fall. Those are two different scenarios, and we really don't know which one it is with this guy, do we? Because if he had a hemorrhagic stroke, we want to get our blood pressure down to prevent that bleed from expanding. But if he had a TBI that happened after he fell, we want to keep the blood pressure up. Do you see what our conundrum is here? And I'm going to add a little bit more in a bit. So you could say, let's just ride the middle there. Let's let his blood pressure be around 130 because that'll satisfy both of those criteria. And that's okay, but you need to be thinking about it before you start doing anything about blood pressure. So we got him to the CAT scan, and this is what we found. Very interesting. So as we were looking at that, we noticed that he's got a bleed there on the left, and he's got also a subdural on the right. Do we know that this is a traumatic bleed, or could it be an amyloid bleed that caused him to go down and then he gets a subdural? We don't know. We really don't know. So I called radiology and I said, can you help me look at this? And they said, oh, I'm glad you called because I was just going to call you because we want him to come back to the scanner. And I'll show you why in a minute. While I'm on the phone, John shows up. John is our chief neurosurgery resident. He said, I'm here to take this patient to the OR. Now, John is a great neurosurgery resident. He stalks the board in the ED. And when blood shows up anywhere, there he is, if it's in the brain. I said, John, I want you to go talk to radiology because they have a concern about this scan because we scanned all the way through. Now, in case you didn't catch that, radiology was worried about this hematoma at the lower pole of the kidney on the left. And they were wondering if this was extravasation. Is this an active bleed? What's going on? So they wanted him to come back to the radiology suite. So I sent John to go duke it out with radiology because if he took that patient to the OR to do a craniotomy and they've got an intra-abdominal bleed, that could be disastrous. And they had to work out those details. In the meantime, we intubated the patient. Now, what we use for intubation is etomidate, rocuronium. We gave him 50 of fentanyl before that all, and we were watching his blood pressure. Still, we don't really know what's going on as far as did he bleed and fall or fall and bleed, but we're trying to be careful with our blood pressure. We don't want big movements irrespective. So he was intubated well, and he did end up going to the OR with John, and they did a craniotomy. You can see the pneumocephalus. You can see that they took care of that subdural for the most part. And you can also see that the parenchymal bleed on that left side has expanded. Partially probably because of some fluid resuscitation, partially because that's what those bleeds do. And it turned out that he probably had a traumatic bleed altogether. And he also got some blood in the ventricles. So all of this portends not a great outcome. As it turns out, he didn't have an active bleed in the abdomen, and he did pretty well. He came to clinic about a couple of weeks ago, and he's doing well. He's reading. but he's not driving, he's not riding his bike, and he's got some lasting problems from the traumatic brain injury. But he's 80 years old. I think he did fairly well for what he had. So the pearls from this case is the history is really important. In emergency medicine, we are the big picture. We communicate with pre-hospital. We need to talk with our EMS folks, get the picture, get as much information as they have, talk to the family, and figure out the big picture. The neurosurgeons are worried about the brain. The trauma surgeons are worried about the abdomen, but we are there to bring the whole big picture together and try to figure out the best course of action. Remember, not all blood pressure goals are the same. If you have a spontaneous bleed, you want to bring that blood pressure down. If you have a TBI, you want to keep that blood pressure on the higher side. And look at your clues. This is intuitive. When this guy fell off his bike and he was perseverating and had amnesia, he's got TBI. We know that. And with TBI comes ICP. So use your intuition and manage your blood pressures well for whatever you have going on, and you will improve the outcome for your patients. So thank you very much. It's great to be here, and I look forward to lots of questions for the panel.